Our second case is a patient with high-risk non-ST elevation MI in which a DK crush technique was adopted. I have no potential conflict of interest. Our patient is a 70-year-old male. He is known to be diabetic and hypertensive and presented to us One Heart Center with high-risk non-ST elevation myocardial infarction and in acute pulmonary edema. His electrocardiogram showed ST segment depression, diffuse, and ST elevation in AVR. His echocardiography showed wall motion abnormalities in the territory of the LAD, and the patient was soon rushed to the cath lab and mechanically ventilated. His right coronary angiogram was normal. His left coronary angiogram showed distal left main bifurcation lesion of Medina 111, significant lesion involving both the ostia of the LCX and the LAD. So, and the patient also had some degree of calcification in the proximal and mid segment of left anterior descending artery. So we calculated the Syntax score. It was around 23. Syntax score 2 for PCI and CABG, and we finally went for a heart team discussion while the patient was on table, and we favored to go for PCI. At this stage, we chose to adopt the DK crush. So we started with a predilation to both the ostium of the LAD and the ostium of the LCX, followed by kissing balloon. The balloons used were a non-compliant balloon, 2.75 times 15, which we usually choose when there is an ostial disease being fibrotic. Then the first step of the DK crush technique was with deployment of a 3 or 14 millimeter drug-eluting stent in the side branch, which is here the LCX. And note that there was a non-compliant balloon in front of the ostium of the LCX ready to crush the stent after its deployment. Then we removed the wire and crushed the stent using a 3.5 times 18 millimeter non-compliant balloon at high pressure. The next step is one of the most important steps in the DK crush, which is recrossing of the side branch through the proximal strut. As you can appreciate here, this is a proximal strut crossing. Note that we do not go for a pullback technique when you recross the crushed stent. You, as much as possible, try to cross through a proximal one. This is a zoomed one, so you can appreciate this is away from the carina and towards the other side of the wall. Then you perform the first kissing balloon inflation using non-compliant balloons. Back to the wire recross, again, this is an illustrative image. When you crush the stent of the side branch, you actually push more struts toward one side away from the carina, and at this stage, the carina will be bare without any struts across it. So when you inflate a non-compliant balloon here across the crushed stent, you actually reform the proximal part of the crushed stent so that the carina will become covered again with metal. But if you adopted the pullback wiring like this image, we will fall in the area that is not covered by metal, because this is the easiest way to cross the stent instead of negotiating a crushed segment. If you inflated an uncompliant balloon here, you are actually crushing more struts to the other side of the wall and leaving the carina bare, and this will lead to future restenosis. After that, you have to ask yourself a very important question: what is your shortest non-compliant balloon on shelf? Because you are going to deploy the main vessel stent. So when you deploy the main vessel stent, you have to choose the size of the proximal part to the carina. And in this case, we are pretty sure that the shortest non-compliant balloon will be definitely equal to the left main. So we decided to go from the ostium of the left main into the proximal part of the LAD. And after we deployed a 3.5 times 38 millimeter stent, there was dissection flap at the distal edge, which was securely covered by a 3.0 times 20 drug-eluting stent. This was followed by a non-compliant balloon inflation across the whole metal with pot and flaring to the ostium of the left main stent. Of course, we have to pot before we recross. Notice that we now have a wire in the LCX side branch beyond the struts of the left main stent. So we have to do proper pot before we recross in order not to go again beneath the struts. This was followed by the second kissing balloon inflation at high pressures using a 3.5 and 3.25 millimeter balloon. And again, we will do the final pot to the left main proximal to the carina, followed by flaring of the ostium of the left main stent. This was the final angiogram, and as routine, we do an intracoronary imaging after left main stenting. So the OCT image showed that the minimal stent area is 15.5 millimeter cube. So my take-home message today is that the DK crush technique is a preferred strategy, preferred to stent strategy in distal left main bifurcations, provided that you do have a proper angle to go for a DK crush. It can be also performed in high-risk patients, provided that you have the proper steps and you are well trained on. Note the final details, because this usually affects the future outcome of the DK crush. Note the proximal wire recrossing of the side branch stent. Note that you have to know what is the shortest non-compliant balloon to determine the length of the main vessel stent. Intracoronary imaging is definitely mandatory in all patients who have left main disease and underwent left main stenting. And please keep in mind that the DK crush you have to rewire twice, you have to pot twice, and of course, according to the name, you have to kiss twice. Thank you.
Thank you. I think this is almost like an illustrative case to show the DK technique step by step. So any comments or questions? Dr. Amin, please.
Yeah, good afternoon. Actually, in this case, why you preferred OCT over IVUS? Because we are going for LMCA.
No, it was according to the availability. Actually, in this particular case, it will be better to use an IVUS because we went to the ostium of the left main. But it's only according to the availability of catheters. In this case, it was available. OCT was available, so we choose OCT. But definitely, IVUS would have been better.
Thank you.
Was the case done under any sort of support?
No. No, he was completely stable all through.
Okay.
And did you pot? When did you start potting? Can you take us back to the very first, if you don't mind?
No problem.
Okay. So tell us when. Before the you double kissed regularly, and then you put the stent and crushed it.
After you deploy the main vessel stent, you pot before you rewire.
Yeah,
it's not.
So that's important.
Yeah, because there was a false belief before that you should rewire first in order not to trap the side branch wire after you pot, but this is definitely not true. You have to pot before you recross, otherwise you can definitely go beneath the stent struts again.
Yeah.
Just to make it simpler, would you prefer to doing some sort of a tap or something in a very complex left main as opposed to double kissing with lots of metal inside?
Oh, yeah. Look, personally and in our center, actually, in this particular case, we usually prefer to go for a DK crush technique. Tap, actually, we don't prefer tap unless you have an angle more than 70 degrees. Because, in this case, you don't have much metal inside the left main. On the contrary, the crushed stents are actually beyond the left main stents. When you go for tap in this acute angle, you will have a flow divider, a new flow divider inside the left main stent. So we actually prefer the DK crush.
But the real answer to your question is we really need a randomized trial of DK crush versus tap, because tap is a much simpler technique than DK crush. And whether or not it's going to influence the MACE rate is what everybody would be interested. DK crush has good data. With good follow-up, but TAP is simpler, give you a good angiographic result, you save a few steps, and we don't know. I mean, it has the downside that you're protruding some stent in the carina, you're reforming the carina with a stent, and we don't know what that means in the future. So,
practically speaking, we're talking about a left main, a very complex left main, and obviously there is a chance of error or something as well. So make it simple. I don't know, but I agree with you. I think there is no randomized trial. That would make things much more clearer.
I think it's a matter of the angle. If you do have an acute angle, probably tap is not the best option. That's my opinion.